intersphincteric fat plane. Stage 3, involvement of the intersphincteric fat plane, and then stage 4 are involvement of the external sphincter. What about the end staging? End staging stands for nodal staging, and basically we have two important stages. N1 disease is less than 3 lymph nodes involved around the rectum, and N2 disease is more than 4 lymph nodes around the rectum. And nowadays we don't depend on size anymore. We depend on the shape, border, and the segment characteristics of the lymph nodes. So whenever we have a large lymph node but has a healthy appearance, that's it, that's not non-specific, but if it is small and even having the regular appearance, or a regular outline, is very suspicious when we look at a lymph node. What are the diagnostic clues we follow on workstation whenever we look for lymph nodes? Usually we look upon lymph nodes regarding the shape, so whenever the lymph nodes are uniform, smaller than 10 millimeters, and homogeneous signal intensity, they are not suspicious. Lymph nodes with irregular borders, mixed signal intensity, or both, they are very suspicious. And then, like I said before, N1 is less than 3, 4 and more is N2 disease. And any lymph node, and this is a very important point here, any lymph node lying less than 1 centimeter from the mesorectal fascia, it can involve mesorectal fascia by tumor, and that's the point where we call it a CRM positive disease, even if it's not the tumor itself involving the CRM. The lymph node involving the CRM is a CRM positive disease. This is an example such a T2 weighted image for the lower rectum mass or mid-rectal mass with 2 lymph nodes involved in the perirectal fascia, easily detected. Nowadays we use even diffusion weighted MRI sequences to detect the affected lymph nodes. What is the C? The C stands for the CRM, circumferential resection measurement. This is very important. The mesorectal fascia is usually well demarcated in MRI as low signal intensity line around the rectum, outcircling the fat around the rectum, and usually it's easily seen in T2 images. And lately we discussed the issue about the MRI, whether we should inject contrast or not, and we found that even without contrast, you can anatomically localize the tumor very well and accurately stage the tumor, and by using just T2 sequences. This is an example of the location of the mesorectal fascia. It should be the dashed line here, and then this is the location of mesorectal fascia as well. The tumor is away from mesorectal fascia as we see, but the lymph node is involving the mesorectal fascia, so CRM positive. Again, another example, large tumor or circumferential around the rectum with involvement by the tumor as well as the lymph nodes. The last example, and very important example here, is where's the arrow here? This is involvement of the extramural vascular invasion of the vessels by the tumor as well as the lymph nodes. Both of them are involved, violating the mesorectal fascia and causing the tumor to be CRM positive. And the tumor itself is away from the mesorectal fascia. Let's jump into the extramural vascular invasion. What is the EMVI? It stands for, it occurs usually in half of the cases. It's very important. Usually we call it EMVI whenever we have a T3 tumor or above. Never T1 or T tumors cause EMVI. Can we see it easily by MRI? Yes, we can see it easily. Usually the vessel distends and it has an irregular outline and filled by tumor, even without contrast. So, what is the importance of EMVI? Usually those tumors have poor prognosis, and usually, sometimes even, you see those tumors having liver deposits early in the disease itself. This is an example of T2 weighted image where we can see the tumor, and the arrowed are the normal vessels. Normal, thin, dark vessels with no distension, no tumor filling them. This is normal appearance, don't get confused to it. And then this is the appearance of the EMVI, where the tumor is extending into the vessel itself, extending it and causing some sort of abnormal signal inside the vessel. And then this is another example of EMVI, where the vessels are involved here by the tumor itself. Okay, so this is a diagram describing how the vessels should look. On the A side, those are the normal vessels. On the B, C, and D side, those are the abnormal vessels, whether they are distended, filled by the tumor, abnormal signal intensity, or nodularity in the vessel around it. So to summarize it, why MRI is important? Because this is the only tool used for diagnosis of rectal cancer patients. CT is obsolete. It's not. It doesn't have a word anymore in staging of rectal cancer. It has a word for M disease, like distant metastastic disease. And to summarize the MRI report, we should follow the mnemonic that we created, and I'm proud to create this kind of mnemonic, because every radiologist, if they follow this mnemonic, they won't miss the findings, and they will address accurately the answers to the clinicians and oncologists. And as we said, this distance is the word, just remember it. stands for distance from the lower part of the tumor to the skin, T for staging, A for anorectal complex, and for nodal staging, C for circumferential section margin, and E for extramural vascular invasion. I would like to thank you very much for your attention, and this is my email address. Whenever you have a question, just send me, and I'll be glad to answer it. Thank you so much.
Thanks, Professor Hisham, for your good presentation. Lastly, Professor Khorshid will present metastatic colorectal cancer, how to choose the first line treatment.
Thank you so much, Mr. Chairman. The main topic of our Congress is bridging gaps in oncology. And one of the important gaps that we have, and one of the important questions is, for the RAS wild patients, colorectal cancer patients, how can we choose the best treatment to get the best results for our patients? So we usually choose our treatment based on two important things: the clinical scenario, how is the patient presenting to us, whether the patient has a potentially resectable disease or resectable, because this is how we're going to plan the treatment based on this, and whether or not the patient is having RAS mutation, because we do have, this is predictive for EGFR inhibitors. So if you have a patient who has a resectable or potentially resectable disease, you need to resect this disease because you will improve the 5-year overall survival of those patients by 50%. For your unresectable or symptomatic patients, the main goal is to control the symptoms, so you need to control the response rate and improve the overall survival. So definitely your front line should aim for improving the response rate. Use a regimen that will give you a very high response rate so that you can go for the R0 resection and cure and control the symptoms, and also to give you a high overall survival benefit. So these are the available tools that we have. We have the doublet chemotherapy. These are the effective doublet chemotherapy and the triplets that we use in some options. And the biological agents, we have now a plethora of drugs. We have the EGFR inhibitors, the humanized panitumumab, and the chimeric cetuximab, the anti-angiogenic agent, the bevacizumab, quercetin, and graftin. And the question is, how can we best combine these drugs in order to sequence them, in order to give the highest response rate and highest overall survival, and hence improve the quality of life. Now, with chemotherapy, apart from IFL, which is now obsolete, no one uses the IFL, you would expect with the doublet chemotherapies to get the response rate in the ranges of 55%, and R0 resection in the ranges of 9-10%, progression-free survival of 8 months, and overall survival of 17 months. When you give the triplets, you are improving the response rates to 60%, resectability will improve to 15%, however, you're not really improving the progression-free or overall survival with the triplet. So these are the results that we get with chemotherapy, and the question is, can we improve on this? Now, EGFR receptor is overexpressed in most colorectal cancer patients, and what happens is that the ligand, when it attaches to the receptor, it activates a cascade that leads to a signal transduction that leads to cell proliferation, metastasis, and angiogenesis. Now, what the EGFR antibodies do is that they inhibit the antibody from the ligand from attaching to the receptor, and hence they inhibit the signal transduction pathway. However, in around 40 to 50 to 60% of the patients, you will have what is called a stress mutation. And in these cases, what will happen is that there is an inherent activation of the signal transduction that is irrespective of the EGFR receptor, and this is why we are having EGFR antibody resistance for patients who have RAS mutation. So we used to test for exon 2 KRAS mutation, and it was mutant in around 48% of the patients. However, now we know that in the KRAS wild, we have an extra 20% who are mutant. They have the mutations in other exons, such as exon 3, 4, and we have the MRAS, and all have been found to be predictive for poor response to EGFR antibodies. And now it is mandatory to test for the pan-RAS. We don't test for the KRAS anymore. So for our RAS wild patients, the options of treatment that we have now are either to give the vascular growth factor, bevacizumab, or to get the anti-EGFR. How can we choose the frontline treatment for those patients? And remember, our goals are again the response rate, the overall survival of patients. Now, with bevacizumab, in terms of responses, all of the trials that looked at bevacizumab, when combined with doublets, none of the trials did show any improvement in the response rate, apart from when bevacizumab was added to IFL, and we know that IFL is obsolete now. Progression-free survival is expected with bevacizumab and a doublet is around 10 months. Overall survival, again, has not been increased except in the trial that used IFL, and it's in the ranges of 20 months. So these are the results that we get with bevacizumab. And what about patients who are liver-only metastasis, and what are the resection data when you add bevacizumab to chemotherapy? Bevacizumab did not increase the resectability, and the R0 resection is in the ranges of 7 to 12%, and when you add it to a triplet, it goes up to 26%. And recently reported was a TRIBE trial. This was a phase 3 trial that looked at FOLFIRI, bevacizumab with FOLFIRI or FOLFOXIRI, and it didn't with bevacizumab and FOLFOXIRI, the maximum that you would get is a response rate of 65%, but again the R0 resection is only 15%. Median progression-free survival is 12 months, and overall survival of 30 months. So how can we improve on these results? The EGFR inhibitors, together with chemotherapy, were aiming at improving, beating the results of the 15% resectability and the 50% overall response. So EGFR in the phase 3 trials and the phase 2 trials, I'll start with the PRIME trial, which randomized patients, more than 1,000 patients, to FOLFOX with pembrolizumab or no pembrolizumab. Response rates increased to 60%. Progression-free survival was 10 months, and overall survival was 26 months. Similar results were seen with cetuximab. Again, the responses are higher; they are in the range of 60%. The progression-free survival is in the ranges of 9 to 10 months, and the overall survival is 24 months. We knew, and now we know, that we should not combine, especially the cetuximab should not be combined with capecitabine or bolus IFL, bolus fluorouracil. You will lose the efficacy of the cetuximab. And when the cetuximab or the EGFR inhibitors were combined with the doublets or the triplets, the R0 for patients who were selected for resectability, the R0 resection was 38% with the doublet and 60% with the triplet. And this is something that we did not see before. Remember, it was 15% with the bevacizumab. And now, more and more, we're talking about what's called as the early tumor shrinkage and depth of the response, and we know that this correlates with the overall survival. You can see that the depth of response with when you add pembrolizumab to chemotherapy, it is deeper, and the overall survival is significantly longer for patients who achieve tumor shrinkage and early tumor shrinkage. Progression-free survival for a patient who achieves more than 30% reduction of the tumor within 8 weeks is 15 months compared to 9 months, and the median overall survival is 34 months. So this is an important aspect that we need to look at for our patients and aim for. So if you ask the question, what would be the best agent to use as frontline that will improve on the results of chemotherapy, that will give you the best response rates and R0 resection, it will definitely be the EGFR inhibitors. You will get a 55 to 60% response rate. With the doublet, EGFR inhibitors will increase the resectability to around 30%, the R0 resectability, and with the triplet it's 60% compared to only 15% for bevacizumab. And if you're asking the question that we should all be asking now, what's just the best agent that will give us the early tumor shrinkage, more than 30% within 8 weeks? Again, it is the EGFR inhibitors, where you will achieve an early tumor shrinkage in 60% of the patients. So it is a point of debate, and this is why we are having head-to-head trials that have compared bevacizumab with the EGFR inhibitors. We have 3 trials. We have the PEAK, this was a phase 2 trial, and we have the FIGHT-3 and the cancer leukemia group B. All are asking the same question. The PEAK was randomized around 300 patients to either pembrolizumab with FOLFOX or bevacizumab with FOLFOX. The first randomized 600 patients to FOLFIRI with cetuximab or bevacizumab, and the cancer leukemia group B, the 2 arms that were running were whichever doublet, FOLFOX or FOLFIRI with cetuximab or bevacizumab. Now, these are the results of the PEAK trial. There was a significant improvement in progression-free survival when you add pembrolizumab to chemotherapy. You have a 3.5-month improvement 13 months compared to 9.5, it has a ratio of 0.65. Now, interestingly enough, in that trial, the overall survival for the wild RAS patients was 41 months if you add bevacizumab compared to FOLFOX, bevacizumab FOLFOX of 13 months. So we have an overall survival benefit of 12.4 months just by changing the target treatment that you add to chemotherapy. And this improvement has been shown, and although the hazard ratio in the overall survival was 0.6, however, the p-value was 0.058. But remember, it was a phase 2 trial. And the overall survival benefit was seen in all subgroups of patients. And if you look at the early tumor shrinkage, it was significantly higher when you add the panitumumab compared to bevacizumab. The overall responses were significantly higher. The early tumor shrinkage was higher. Median overall survival again was higher. Similar results was seen with the FIRE3. FIRE3 initial results were on exon 2 mutations. You couldn't see significant improvement in responses or progression-free survival. The overall survival in the KRAS2 was only a 3-month improvement in overall survival. However, when they did the pan analysis and they found that the exon 2 that within the wild KRAS there were 20% who were RAS mutant, and they did the reanalysis, the overall responses, you can see it improved to 72%, and that was statistically significant. If you add rituximab to FOLFIRI, that response was greater, which correlated with overall survival. And the overall survival for the RAS wild patient was 33 months. So if you get the chemotherapy followed by rituximab, you are likely to start, if you start with this regimen, you are likely to get an overall survival of 33 months. If you start with bevacizumab, the overall survival is 25 months. So an 8-month difference. And why is this? Well, they looked at the second-line treatment for the FIRE3, and they found that 50% of the patients did receive 50% of the rituximab arm, they received bevacizumab, and in the bevacizumab, 50% received EGFR antibody. So what about the sequence? Maybe it's the sequence that is explaining what's going on. And the interpretation of this trial is that if you start with the rituximab doublet, and then you follow this with a progression with bevacizumab doublet, the overall survival is 33 months. And if you start with a doublet with bevacizumab followed by rituximab, the overall survival is 25 months. Difference of 8 months, just by changing the sequence, although you're using the same drugs. And why is this? Because there seems to be, for patients who have a resistance to anti-EGFR, there is an upregulation of the pro-angiogenic factors. And in phase 2 trials, when they looked at the progression-free survival when giving bevacizumab a second and third line, there was actually an overall response that was 40% as a single agent, and this is not seen before, and a median progression-free survival of 26 weeks. Again, it is equivalent to like when you're giving it the first line. And there was again, with the FIRE3, a significant early tumor shrinkage when you add rituximab to compare to bevacizumab. The third trial was the cancer leukemia group B, more than 1,000 patients. Again, as I said, randomized to doublets with rituximab or bevacizumab. They only tested for the RAS for only 50% of the patients. It was planned only for the KRAS in the beginning. And in this trial, although there was a significant improvement in the overall response rate, however, there was no difference in progression-free and the overall survival. And the problem with this trial is that the RAS analysis was only done in 55% of the patients. We don't have any data on the first-line treatment, on the duration of the first-line treatment, and what was the second therapy that the patients received, and its duration, which might explain why are we having these poor results. So if you're looking for the drug that will improve your overall survival, clearly from the trials that compared the rituximab and the EGFR inhibitors, it seems that EGFR inhibitors are doing better. With panitumumab it's 41 months, with rituximab it's 33 months, just by using the sequence I told you. If you look at safety, especially for your patients who are going to go for resectability, we know that bevacizumab is associated with excessive bleeding, perforation, impaired wound healing. You need to at least wait for a month to send the patient for surgery. And there is an impaired hepatic regeneration and post-vein embolization. These, and we know that the half-life of bevacizumab is 20 days. Now these side effects are not seen with EGFR inhibitors. You will get the diarrhea, you will get the rash, which can be improved by preemptive treatment, hypomagnesemia, which can easily be treated, but you will not get the problems that you will see with surgery. And if you compare peritoneumab and cetuximab, it seems that the fatal adverse events are lesser with peritoneumab. It's around, it is 29, it's 5% compared to 9.9%. So if you're looking again at safety, especially for your patients, when you're going to go send them for surgery, then you will probably use the EGFR antibody. And this is a meta-analysis that was reported quite recently, more than 1,000 patients from the 3 trials. You can see there is an improvement, there is a favoring overall survival with the EGFR inhibitors, especially in the KRAS wild. Only in the KRAS wild, if you have a wild KRAS with mutation in amyloidosis, you don't get this benefit, so it is imperative that you test for the pan-RAS now. The progression-free survival, again, there seems to be a benefit with the EGFR inhibitors, and overall response rate, again, it is actually low. So the take-home message for metastatic colorectal cancer patients: if you need to test for the RAS mutation, if you have RAS wild, these are important patients to detect, because you are likely going to improve the overall survival of those patients for more than 14 months. You need to start the sequence, as I said. Better to start with a doublet with an EGFR inhibitor, with a peritoneumab or cetuximab. We've seen the big trial, overall survival 41 months, to 5 is 33 months. Second line, doublet with the bevacizumab, and the third line can always use regorafenib. With the RAS mutant, doublets with the bevacizumab and regorafenib. And indeed, the deeper the response and the correct sequence is the best way to go to improve your overall survival. Thank you.
Thank you, Professor Horschel, for your good and scientific presentation. And now we can go to the floor for discussion regarding the first what is the appropriate view of the radiotherapy locally advanced rectal cancer. Professor Salim and Professor Yossi. The second presentation, Professor Ahmed Mustafa, laparoscopic colorectal surgery. The third, Professor Sharwanta, MRI and staging of colorectal cancer.
Thank you again for the very nice presentation. MRI is mandatory in staging of rectal cancer. I believe personally also the same. But a new technique is developing. This is the PET MRI. Combining PET, not with CT, but with MRI. And I think some devices are already existing. What do you think about it?
Actually, the PET MRI is a new technique. It's not available that much in Egypt itself, even starting to evolve in Egypt now. But basically, when we talk about the tumor, we talk about two things: the size of the tumor and the extension. And those are the methods that we see in MRI, and it's quite obvious that we can stage well by MRI. What about the activity? The activity is important, but it's not important for accurate staging, except when you talk about lymph nodes. So lymph nodes have been always the debate. And if we talk about small lymph nodes that look like benign lymph nodes, and then you turn after surgery to be malignant, this is the defect that we face in diagnostic radiology. We are doing static imaging. It's not dynamic imaging. Dynamic imaging is functional imaging, is defects, basically defects and the function of the tumor itself. So for the T-staging, we don't matter. The MRI would be suitable very much, but about the end staging, the PET-CT would play a great role here. PET-CT or PET MRI, actually. Thank you so much.
Thank you.
Professor Horschel, metastatic colorectal cancer, what is the frontline treatment?
My
name is Yasna Eder from Aswedai. I would like to thank Professor Ola Washington for her nice presentation. That's what's very strange to me in the treatment algorithm. I didn't see the ramucirumab or Cyramza or even aflibercept in your treatment algorithm.
You're absolutely right. I was focusing mainly on the frontline treatment. I wanted to send the message. I wanted the message to be very clear.
According to your data, your presentation, I will jump from Volvox Avastin in failure after failure to Stivalent.
But why would you give Avastin in the frontline?
No, I'm talking about your decision for treatment algorithm, your proposed treatment algorithm. Yes. When the patient is under Xelox or Volvox Avastin and there is progression, I go directly to Stivalent or Avastin.
Again, if you're giving the patient a doublet, you should give it with an EGFR inhibitor if the patient is RAS-wild. And then, when the patient progresses, as you have seen, the sequencing is important, and you need to give bevacizumab as second line. So the thing is, now we should be giving bevacizumab as second line, not as front line.
Okay, I do propose, if you allow me, in failure of Avastin, I have three choices: either to continue based on the data of the TML, Avastin beyond progression, or to go to aflibercept, or to go to ramucirumab or Cyramza. There is three options.
Yes, of course.
And then the fourth option will be Stivalent. Thank you.
Thank you very much. Dr. Yasser is a renowned figure in, especially in GIT cancer.